Dear all, welcome back for NephroTube online nephrology lectures. This lecture I will talk about the KDIGO 2021 Clinical Practice Guidelines Update for the management of lupus nephritis. This is my talk outline. I will start by lupus nephritis diagnosis. If there is any suspicion for for systemic lupus erythematosus or suspicion of its flare, the testing panel to detect if there is renal involvement or not is by doing serum creatinine, urine analysis, dipstick, and sediments by microscopy, spot protein creatinine ratio, and for serology, we have to do anti-double-strand DNA and complement. If there is evidence of abnormal proteinuria or urine sediment in the form of abnormal proteinuria by dipstick more than or equal to plus with any level of specific gravity, or dipstick protein 1 plus with low specific gravity, or spot protein creatinine ratio more than 500 milligram per gram. All of these with or without urine sediment positive for dysmorphic RBCs more than or equal 5%, or the presence of red cell casts or white blood cell casts. So here we are in activity of lupus nephritis. If there is no evidence of abnormal protein or urine sediment, so no further urine testing at this time. If yes, there is an evidence of abnormal protein or urinary sediment, we have to quantify proteinuria by 24-hour urinary protein. If 24-hour urinary protein is equal to or more than 500, you have to consider kidney biopsy. If not, you have to repeat the test and follow the progress. If the proteinuria increased, you have to do biopsy. If not, you will follow up the patients. From the start, if there is evidence of decreased or decreasing GFR, for example, abnormal eGFR that is below the expected level based on age and clinical history, or decreasing eGFR with no attributable cause other than systemic lupus. If yes, repeat testing and consider biopsy. If no, so no further kidney function testing at this time. So this is how you will handle cases of systemic lupus erythematosus presented with renal affection. As we all know, in the biopsy score for lupus nephritis, there is what is called activity index and what is called chronicity score. When the activity index is high, that means that the specimen of the biopsy is in active inflammatory state, while if the chronicity score is high, that means that this kidney is losing function and a lot of sclerosis and fibrosis is in the specimen. Multiple parameters will be indicating the activity index and also multiple parameters indicating the chronicity score. The activity index is from 24 because for the fibrinoid necrosis it is multiplied by 2, and for the cellular fibrocell crescents it is multiplied by 2 also. That's why you will find the activity index is has a more interval of number more than the chronicity score. You may find other histological findings in patients with lupus and lupus nephritis rather than those present in activity index and chronicity index, as lupus podocytopathy by the presence of food process effacement, collapsing lupus glomerulopathy, and many other vascular lesions. According to lupus nephritis pathological classification, we have 6 classes. At first class, there is minimal mesangial lupus nephritis. In this case, the glomeruli by light microscopy are normal, but you can find deposits by immunofluorescence. Then class 2, more mesangial proliferation. This is called mesangial proliferative lupus nephritis. Then class 3, you will have focal lupus nephritis, and class 4, you will have diffuse lupus nephritis. And in focal lupus nephritis, it is classified according to the activity and the chronicity index into active or chronic or active and chronic at the same time, according to the score that I was mentioned in the past slide. Regarding the diffuse lupus, it is also divided into active, chronic, and active and active chronic, but also this is divided into segmental and global according how much from the glomerulus itself is affected. Is less than 50% of the glomerulus is affected, so it is called segmental diffuse. If more than 50% of the glomerulus is affected, so it is called global diffuse. And the class 5 lupus nephritis is in the form of membranous nephropathy. And finally, class 6 is advanced sclerosis, when there is more than 90% of the glomeruli in the biopsy are globally sclerosed. Let's go through the treatment of different classes, starting by class 1 or 2 treatment. In class 1 and 2, if there is low level of proteinuria, you will make general supportive treatment, and you will give only immunosuppressive treatment only guided by extrarenal manifestations. You will treat extrarenal manifestations of systemic lupus by steroids. If the patient is presented with nephrotic syndrome, you have to evaluate for lupus podocytopathy by electron microscopy, and you have to treat the case as minimally changed disease. And finally, you have to consider maintenance combination therapy with low dose glucocorticoid and another immunosuppressive agent. For class 3 or 4 treatment, we have the induction therapy and the maintenance therapy. Starting by induction therapy, if the patient has class 3 or 4 plus or minus 5, if you find class 5 with 3 and 4 in the biopsy, you will treat as 3 or 4. You will check is there is concomitant thrombotic microangiopathy. If yes, we'll discuss another protocol or algorithm later in this lecture. If no thrombotic microangiopathy, assess activity and chronicity. If they are active, so you have to give corticosteroids, and you will find here that steroids is given at lower dose than it was mentioned in KDIGO guidelines 2012. Methylprednisolone IV 0.25 or 0.5 gram per day for 1 to 3 days, or then prednisone by 0.6 to 1 milligram per kilogram per day, maximum 80 milligram, and then you will taper over a few months, as we will say, to maintenance dose. If the pathology is showing chronicity without activity, you will give general supportive treatment for chronic kidney disease. But if there is concomitant class 4, if there is concomitant class 5, manage as class 5. As I said, that the dose of corticosteroid here is lower than the previous guidelines, because emerging data suggest that lower doses may be equally effective, but with fewer short and long-term toxicities than large doses of steroids. Then we can give with corticosteroids other immunosuppressive drugs. We can give calcineurin inhibitor in the form of tacrolimus and reduced dose mycophenolic acid for 24 months, or we can give voclosporin and mycophenolic acid in patients with GFR more than 45 for 52 weeks. The voclosporin regimen is significantly glucocorticoid sparing regimen, and will hopefully reduce the glucocorticoid adverse events that often seen in lupus nephritis treatment. We can also mix with corticosteroids mycophenolic acid analogs for at least 6 months in the form of MMF 1 to 1.5 gram twice daily, or mycophenolic acid sodium. Also, we can combine with corticosteroids cyclophosphamide also for up to 6 months in the form of 3 regimens. The first one, you can give cyclophosphamide intravenous 500 milligram every 2 weeks for 6 doses, or 0.5 to 1 gram per meter square monthly for 6 months, or oral cyclophosphamide 1 to 1.5 milligram per kilogram per day. So we have different protocols for the cyclophosphamide: the NIH protocol with the large dose of cyclophosphamide, the Eurolupus protocol with lower dose of cyclophosphamide, and the oral cyclophosphamide. Actually, the intravenous cyclophosphamide with the large dose efficacy data included patients of different races and ethnicities. also for the oral cyclophosphamide. But for the intravenous lupus regimen, efficacy data was mainly from Caucasian patients, with some data from other ethnicities, so its action in different ethnicities is not approved. Finally, you can add B lymphocyte targeting biologics by using belimumab in combination with mycophenolic acid analogs or cyclophosphamide. Also can use rituximab as an add-on therapy for refractory cases or for corticosteroid minimization. Actually, the use of B cell targets at rituximab and belimumab is an off-label use. It is not the first line recommendation. It is discussed in a practice point because of the positive data from recent trials demonstrating that these biologics are effective in lupus nephritis and have favorable safety profiles. Regarding belimumab, the optimal use of belimumab in lupus nephritis will become clear as its use increase, as it was tried in multiple studies, and it gave a very good effect in comparison to placebo. A final point about the multi-target regimen, it is the combination of glucocorticoid, MMF, and calcineurin inhibitor. It shows good efficacy compared to cyclophosphamide, by the way, because the multi-target regimen hadn't been studied in diverse of lupus population. It wasn't recommended at first line, but suggested as an alternative for MMF or cyclophosphamide. There are other therapies that can be used in the management of class 3 or 4 instead of what we mentioned before in conjugation with glucocorticoids, as azathioprine or leflunomide with glucocorticoids. Actually, this can be used if the patient is intolerant to what we mentioned in the last slide, lack of availability of the first line recommended drugs, or excessive cost, or whatever the cause, to replace first line recommended immunosuppressants with azathioprine or leflunomide. Then we will go to maintenance treatment of lupus nephritis class 3 or 4. Prednisone tapered down slowly till we reach the dose of 5 to 7.5 milligram per deciliter orally. And the KDIGO guideline recommended 3 approaches for how to start prednisolone and how to withdraw it regularly to reach less than 5 milligram or 2.5 milligram at the 25th week of treatment. As we mentioned, that glucocorticoids should be tapered to the lowest possible dose during maintenance, but or except if higher dose of glucocorticoids was required for extrarenal lupus manifestations, so you have to maintain large dose of glucocorticoids. An important point that discontinuation of glucocorticoids can be considered only after patients have maintained complete clinical remission for more than 1 year. So don't stop glucocorticoids totally, except after 1 year of good clinical response of the patient. Okay, after tapering prednisolone, what is the add-on immunosuppressive therapy? The first choice are the mycophenolic acid analogs. Individual indications, we can use azathioprine. If mycophenolic acid analogs or azathioprine are not tolerated or absent, you can use tacrolimus or cyclosporin or mesoribine targeting specific trough levels. Actually, the mycophenolic acid analogs are the preferred treatment for the maintenance therapy, and this is based on high quality evidence. The azathioprine actually is safe in pregnancy and is cheaper than mycophenolic acid analogs. CNI are also safe in pregnancy. Mesoribane data mostly from Japanese patients. Mycophenolic acid analog and CNI, also these data from Chinese and Japanese. Long-term safety data of triple immunosuppression is required before use. The most important point that the total duration of initial immunosuppression plus combination maintenance immunosuppression for proliferative lupus nephritis shouldn't be less than 36 months. As we said, that mycophenolate mofetil is preferred immunosuppressive, and it should be continued for at least 36 months. So patients who have achieved a complete kidney response and have no ongoing extrarenal lupus manifestations will be treated for this duration, as we mentioned again and again. Regarding patients who don't achieve a complete kidney remission and there is proteinuria, repeat biopsy studies have shown that while persistent histological activity is a risk factor for lupus nephritis relapse, many patients who have achieved only partial clinical remission have no remaining activity on kidney biopsy. So may you be in need to redo the biopsy before considering this patient is cured at the pathological level or what is present is incomplete remission of the case. So a more focused use of repeat kidney biopsies may help in managing the duration of immunosuppression in this case. And by the way, some of these cases may develop focal segmental glomerulosclerosis, and the proteinuria that is present now is of the FSGS, not from the lupus activity itself. Protocol repeat biopsy studies have shown that clinical responses and histological improvement of the kidneys may be different from each other at all. Also, you have to know that the biomarkers used clinically for the evaluation of lupus nephritis activity as complement and double-strand DNA also have limitations to judge the case. Therefore, the work group of KDIGO suggested that if a patients are improving, allow 18 to 24 months to achieve a complete response is reasonable in the clinic and outside of the clinical trial settings. And as I mentioned in previous slides, the minimal duration of treatment for this case must be not less than 36 months. Regarding the management of class 5 lupus nephritis, if the kidney biopsy is showing only class 5 lupus nephritis without class 3 or 4, check the level of proteinuria. Is it low level proteinuria or nephrotic syndrome? In both cases, you have to monitor the level of proteinuria and prevent or treat complications as thrombosis, dyslipidemia, and edema as general management of glomerulonephritis. If there is only low level of proteinuria, you have to start renin-angiotensin system and renin-angiotensin system blocker and control blood pressure. The immunosuppressive treatment in these cases is only guided by extrarenal manifestations, and for sure you have to start hydroxychloroquine. If the patient has nephrotic syndrome, you will also start renin-angiotensin system blockade and blood pressure control, and you will give hydroxychloroquine. Combined in this situation, you will need to give immunosuppressives, so combined immunosuppressive treatment with glucocorticoid and one other agents, example for mycophenolic acid analog, cyclophosphamide, calcineurin inhibitor, rituximab, or other cyprin. These patients with low-level proteinuria must be followed up closely because they may progress to nephrotic syndrome and may be in need of combined immunosuppressive treatment. If there is a relapse of class 5 lupus nephritis in case after it entered remission before, so patient should be treated with the same initial therapy used to achieve the original response at first time, or maybe an alternative recommended first-line therapy can be used. Special situations of lupus nephritis, and the first one is lupus nephritis and thrombotic microangiopathy. If lupus nephritis presented with suspected thrombotic microangiopathy, you have to send test for ADAM-TS13 activity and antibodies to ADAM-TS13, and also test for antiphospholipid antibodies. And you have to make thrombotic thrombocytopenic per risk stratification, because if the patient has moderate to high risk, more than 5 points, you have to start plasma exchange immediately and glucocorticoid while awaiting test results, and this is in adults. Okay, after that, if you find that the ADAM-TS13 activity is less than 10%, so this is a case of systemic lupus erythematosus associated with thrombotic microangiopathy, and the treatment will be plasma exchange plus glucocorticoid plus rituximab plus minus cabazitaxel. If the activity is normal for ADAM-TS13 and there is positive antiphospholipid antibodies, so the diagnosis of the case is antiphospholipid syndrome, and the treatment is by anticoagulation plus minus plasma exchange. If there is normal ADAM-TS13 activity and the negative antiphospholipid antibodies, you have to evaluate for other thrombotic microangiopathy etiologies. If there is primary or secondary complement-mediated thrombotic microangiopathy, consider eculizumab. If not, you have to search for other etiologies, secondary etiologies for thrombotic microangiopathy. The second special situation is in pregnancy. It is recommended that patients with active lupus nephritis should be counseled to avoid pregnancy while the disease is active, and or when that treatment is potentially teratogenic, as the use of MMF, and it is recommended to be pregnant only after more than or equal 6 months after lupus nephritis becoming active. Also, to reduce the risk of pregnancy complications, hydroxychloroquine should be continued during pregnancy, and low-dose aspirin should be started before 16 weeks of gestation. The safe drugs during pregnancy are only the glucocorticoids, hydroxychloroquine, azacitidine, and calcineurin inhibitors. Regarding the last special situation, which is kidney failure, patients with lupus nephritis who developed kidney failure may be treated with hemodialysis, peritoneal dialysis, or kidney transplantation, but actually the best preferred method is kidney transplantation, which is preferred to long-term diet. Thank you for watching this lecture, and see you again in next lectures of NephroTube.